Correct me if I'm wrong, Bia.
I tried to turn my microphone, but good morning, everyone. My name is Beatriz Sousa. I'm a PhD candidate, and today I will present part of my master dissertation, who changed my way to see the life and for personal and professional way to understand the people who live with HIV. So I'm very happy to share with you guys some results of my presentation. I don't know if I can present all the research, but I'll try into 1 hour. So you can see my screen.
Yes.
Yes,
Okay.
it's now on presenter mode.
Let me see here. Okay. So, my presentation is entitled Young Adult Living with HIV in Brazil. It's based on two qualitative papers. And one second. Yes. So the agenda for this morning is based on published papers, background and aims, conceptual approaches, methods, the results of first study, and the second one, and some limitation and conclusions of our research. So my master dissertation, I conclude in 2023, was entitled Young Adults Living with HIV/AIDS, Experience and Implications for Healthcare Follow-up. And the first paper is entitled A Part of Me Knew This Would Happen One Day, Experience of Young People with HIV/AIDS. Here the QR code if you want to see all the paper. And the second one is focusing in healthcare follow-up. And we also use the perceptions of young people who experience the service with vulnerability concepts by IDIS. And here the QR code. So just to give background of HIV global context, the human immunodeficiency virus, which causes the AIDS, is considered the complex, the global and dynamic pandemic and affects around 40.8 million worldwide. And in 2024, we had 1.3 million new infections and around 7,000 people died from AIDS related. And when we think in HIV, 4 decades ago, we can talk about the idea of death and infection, the fatal infection. And today, with some strategies, prevention, and treatment, we can see a chronic condition. So in Brazil, we have 1.7 thousand million people living with HIV. In the last epidemiological report, we have 39.216 new cases. But at the same time, the eight cases decreased by 1.5%, and the mortality also decreased by 12.8%. So this both data, we can see we have a new infection into the society, but because of treatment and some strategies to quality of life, the AIDS and the mortality decrease. So the current scenario in Brazil, Brazil was the first, one of the first countries who have universal access to treatment since 1996, free testing, free treatment, and also some combination prevention based on, I don't know how we speak in English, but we talk about the mandala. So I don't know if it's mandala, but it's based some combination prevention strategy to minimize the vulnerabilities and provide the access for some key and priority populations. And also, we have a strong public health response with national programs and testing in counseling centers. Here in Brazil, we call Centro de Atendimento, Centro de Testagem e Aconselhamento, the CTA. And despite all these advances in Brazil, we have a strong biomedical response, but the HIV involves beyond this biomedical perspective. So the challenge into this phenomenon remain care practices, persistent inequalities, and shortage of qualified professional, especially in HIV, which needs um, focusing care for HIV, for listening. So it's very important have some qualified professional, and also the social stigma through the service, the society, and other spheres. So why we focus on young people? Because the youth, 15 to 24 years old, are considered a vulnerable group because it's part of life characterized by biological, sociological, and psychological transformation with sexual development and maturation, the identity formation, and also autonomy search, and this uncertainty and insecurity in this part of life, and also is often reported by the young people a limited sex education, which contributes to health risk behaviors, HRBs, and increased exposure to STIs and HIV. So the young people in Brazil, some epidemiological data, since 1991 to September 2025, we have 25.7% young people living with HIV. And in this population, 66 men aged by 50 to 24 years old. In the last epidemiological report, we had 44 new cases of HIV in men aged 20 to 29 years old. So, beyond the biomedical perspective, the HIV diagnosis is associated with the fear, anxiety, and stigma. And this diagnosis change the identity, the relationship, and the way of this person see the life. So also the stigma and discrimination affect the access to healthcare, the treatment adherence, and some social opportunities. So when we think in young people living with HIV, we can see low engagement into the health service, limited participation in health policy. This is very important, and also insufficient health education, especially for sexual and reproductive health education, and some barriers in care. Involves fear of discrimination into the health service, the non-acceptance of diagnosis, and dissatisfaction with the service. And the justification of our research, it's because most research focuses on, especially in our context, epidemiological data and clinical outcomes, but we need to understand some perceptions of people who live with HIV to try to provide a quality of care for these people, and also treatment and adherence into the healthcare. So the objectives of our paper, the first one is to understand the social representations of young people living with HIV, and the second one to understand the perceptions of this population regarding their healthcare follow-up. For the first paper, we used the social representation theory as a conception approach. This theory was developed by Serge Moscovici. There some ideas from Durkheim, Jean Piaget, and Vygotsky. And the idea of the social representation is based on the reality is socially constructed. So individuals actively participate in the social construction of their lived reality. And this representation are construct with communication and interaction. It's based on the reality of these people and expressed through language and sharing meanings. So this theory emphasizes the common sense knowledge and the collective understanding of reality. So how this theory works, and what the uh, idea of social representation. First, the function is based on four functions, the knowledge. So we try to understand something to explain the reality, the identity. So the social representation is based on identity, especially when some group have the same characteristics. And after that, the orientation, because the orientation guides the behavior, the attitudes, and the justification to support this action and justificate some behaviors. Also, the formation process is based on two process, the anchoring and the objectification. When we introduce a new idea, concept, or thing or idea, we try to uh, transformate the new ideas into familiar concepts and also try to transformate the abstract ideas into concrete images. And also the social representation is based on two systems of thought. The first one, the conceptual universe, and the second one, the scientific knowledge. And both of these systems are mixed to provide a social representation. And when we apply the social representation into HIV, we can understand the meanings, attributes to infection, and also exploring how young people interpret the diagnosis, experience the stigma, and reconstruct the identity. Also is considering the social and symbolic phenomenon. So we focus in personal and interpersonal relationship and resignification of lived experience of this population. The second paper was performed using the vulnerability framework. The vulnerability framework was created by Mann and Tarantola in 1996 and expanded by Iris. It's a Brazilian physician. I didn't found the born, but he's still alive. And the vulnerability based on men, tarantola, and iris is multifactorial and socially constructed and always associated by inequalities, injustice, and social oppression. So the vulnerability framework is based in three dimensions. The first one, the individual, who include behavior, knowledge, awareness, and personal attitudes. The social include inequalities, cultural and economic context, and also the access to information and resource. And the programmatic involves the health service, public policy, and access and quality of care. So when we apply this framework into people who live with HIV, we can also see the structural inequalities, the social stigma, and health system organization. And it's explained barriers to access the care, the challenge in experience, the challenge in adherence and some experience lived by these people. So when we think about this population, we need to create a comprehensive and contextualized care for this population. So the methods for the first paper, the both are qualitative approach, but the first one we use the social representation and reported according to correct guidelines. The data collection was in a specialized outpatient clinic for HIV STI. It's a CTA, and this service reference center for around third municipalities provides the diagnosis, the multidisciplinary approach, clinical follow-up, counseling, and prevention guidance. We had 16 participants, and the inclusion criteria involved aged 20 to 24 years old, confirmed diagnosis, and 3 months in follow-up or more into the healthcare. So the data collection occurred in May to October 2022. We use the interviews guiding for what does HIV mean your life, how did you feel at the diagnosis. We also use the social demographic questionnaire to participants characteristics and the field diary to report some body language, the emotions, and some other things not speeched by the participant. And the duration was around 40 minutes into a private and safe environment. And even we have a small sampling, a lot of participants report the fear and the anxiety to discrimination into the healthcare. So the data analysis was made using Datamotech as a support tool. And Datamotech, it's based on lexical analysis and provides some diagrams, for example, the similarity analysis. And the similarity analysis is based on co-occurrences and semantic structures. It's based on central nucleus of representations, peripheral elements, and the relationships of words and ideas. And also we use the social representation to interpret and understand deeply the idea of HIV, the perspective of young people, try to give the meanings, the symbolic and encouraging process. We also follow that co-expects. Our project was approved, and to keep the anonymous into the participants, we use the letter J for jovem in Portuguese or young in English, and followed by the number of interview. So some characteristics of participants, the our sample have age being around 22.6 years old. The most was male, homosexual, single, 8 years of schooling, and self-declared white. And some participants live with the family, majority with a formal or informal work, and mostly receive 1 to 2 minimum wages of payment. So some clinical characteristics, the participants live with the diagnosis into 2 to 6 years old. The treatment initiate into the first year of diagnosis. The main route of transmission was the sexual way, And also, we identify some risk behaviors, health related by the participants, involving protective sexual practices and drug use like alcohol and marijuana. And this is the similarity analysis that we use to facilitate the organization of corpus and also help to build and construct the categories. And the idea of similarity analysis is based on relationship between the words and the dimensions of this participant and the word person as is the core element of young people living with HIV and is into the center of cluster and into the peripheral systems, including the acceptance, the restarting of life, the self-care, the family support, and some behavioral changes. And we try to put all the results into three classes. The first one represent of this cluster, intitulated Positive Diagnosis for HIV, the new me. And when the diagnosis occurs, that a long process to acceptance and requiring adaptation and understand of the infection and the new adaptation for treatment and follow-up healthcare. And a lot of participants speeches about resignification of the infection, often when they start the follow-up into the service, they talk about, oh my God, I'm gonna dead, or the HIV will kill me, or things like that. And they change this idea into the healthcare and the treatment. And the acceptance of the diagnosis often occurs in an unavoidable reality. And regarding the relationship effective, they have a duality into the trust, a new people or new um, um, partner, and the absences because they have fear to relation to into a new relationship and some behavior change toward safer practice and self-care. Some examples of speeches: the disease itself for me does not mean anything and does not disencourage me to live, to want to grow, to conquer what I want, quite the contrary. And the other one, today I feel strong, a warrior. It's a learning experience. I like to tell people my story. I'm not afraid to tell, and it's a motivation. And I wasn't lucky enough because my partner did not tell me about the infection, and I ended up being infected, and we can't trust anyone. The second class, intitulated HIV in the Face of Ignorance and Stigma, the diagnosis reveals strong emotions such as fear, insecurity, hopelessness, and later resilience. Initially, HIV is often associated with death and loss of life projects. The stigma and discrimination leads to social exclusion and emotional burden. The fear of exposure and judgment is the major challenge for these people, especially on young people. The lack knowledge often reported by these people contribute to risky behaviors and infections, and the outdated perceptions of HIV as a death sentence persist, reflecting gaps in public knowledge. Some examples: deep down, a part of me knew that this would happen one day because I was very responsible about it. Hearing that, the positive diagnosis has blown my mind. At the first, it means death, having to give up everything. My greatest difficulty at the beginning was the fear of exposure, prejudice, and everything that we would care for the rest of your life. And my lack of knowledge, ignorance, made me have attitudes such as unprotected sex, which lead to the disease. And the last class for the first paper involve the dialogue, the acceptance, and necessary respect for this population. The family, especially the mother, is a central source of support and is the first family who these people choose to share the information in the positive diagnosis. The youth vulnerabilities influence the risk behavior, and also the health knowledge, like sex education, is essential for maintaining a health life and quality of life. And when we think about the HIV status to share with the partners, new partners or old partners, it involve a fear of judgment and desire to maintain relationship and explain this duality between talk or don't talk about. And the disclosure decision depends on trust and the seriousness of the relationship, and the dissemination of information about HIV, especially for these people who live with HIV, is essential. And the knowledge need to talk about prevention, transmission, and treatment. And also, when we think HIV, we have some key population with stigma and social discrimination. And when we think in sex education, we have a lack of open dialogue about sexually, especially in specific groups like LGBTQ plus youth. Some examples of some speechless. I feel really sad. I almost got depressed at the first. I didn't want to accept it, but I had a lot of support of my mother. They are going to take advantage of your innocence or because you are having a happy moment. So be careful with the people you walk with and always take the test. I try to share with the partners when I think it's the necessary to do so. Otherwise, as I am aware that I'm undetectable. And I don't know if the problem was the fact that I am gay, being gay and not having access, not talking to other people about sex because of gay sex is different from a straight sex. Some insights of the first paper, we have a contradictory perceptions. At the first, the idea of death by the HIV, and after the understanding and receive the specific knowledge, change the idea and provide a manageable condition. We saw a lot of stigma into this infection because they talk about the fear, the rejection, and discrimination. We also saw the knowledge gap persists, like limitation of sex education and the need to strengthening undetectable to untransmittable awareness. Also, they talk about psychosocial burden, so they felt guilt, fear, and mental health impacts, and the changing of the identity and relationships. And they suggest the importance of support networks like family, partners, health service, and digital space, and also talk about health system challenge like barriers in access, stigma in care, and lack of privacy. For the second paper, we use a qualitative descriptive study grounded in AIDS vulnerability framework. Um, was the same setting of the first study, but we go ahead, Joan.
Muted. Okay, can you hear me now?
Yeah.
Okay, sorry. So I wanted to maybe do a pause and ask if folks had questions for the
Okay.
first paper.
Mm-hmm.
If not, I can start and ask Pia. So for this paper specifically, so was it the first time that you were using the Iramu tech, and did you have to learn to do this analysis?
Sorry, can you repeat, please?
Was it the first time that you were using the Iramu tech software and you had to learn to do the analysis?
Actually, yes, yes. Was my first contact in into Irametec, but I didn't um it it wasn't me who made this analysis into Irametec. I have some help,
Okay.
and after understanding Irametec and how does it work, I sorry, I'm very nervous today.
Don't worry,
But
it's fine. It's fine.
yes, yes, was my first contact with Eramutec.
Okay, thank you. And were you the person that also collected the qualitative that performed the semi-structured interviews? And how was that process for you?
Okay, I think change my way of understand how these people live with HIV because my uncle live with HIV and I truly don't understand how works to him. So was very strong, was very impactful, and was young people like me. So was very, very interesting understanding how they has significant the idea of HIV and try to give some motivation to stay alive and fight for him life. And it's very, very impactful.
Okay, thank you for sharing. That's beautiful. Thank you.
Thank you.
Can I add a question?
Yeah.
Um, I'm sorry if I missed it, but I was wondering, you mentioned the three clusters.
Mm-hmm.
I was wondering how did you decide, oh, this is different if it was like there's in the analysis, there is something that indicates it's three clusters, or analyzing the speeches, you concluded that there were those three clusters that we can see, right? But I
Mm-hmm.
was wondering how do we make that decision when performed?
Okay. So, first of all, we made a lot of reading into the corpus of interviews. So we find some parters, padrões, sorry.
Patterns.
And and, and we saw this first we find four categories and into try to cut the paper. We finally found three, the last three categories, and the Iramutec, the similarly. Let me come back here. We can solve the three categories, but we try to read a lot the material to understand the patterns of this population and try to understand how the words and the relationship into the similarity works and explain the phenomenon. So we have four, but for publication we try to find three categories, and the similarly dendrogram, it's for support the idea of classes, and we use the both approach. So the qualitative analysis based on perception of author as me, and also the Iramutec which support the idea and the separate categories into three categories. I respond to your question.
Yes, thank you.
Okay. Any questions? I can go ahead.
You can go
If
ahead.
you can carry on, Bia.
Okay, okay. Thank you. So for the second paper, which we focus on healthcare, and the experience of healthcare of these participants, was 16 participants, the same sampling, but we focus on other approach focusing healthcare follow-up. So the guiding question for this paper was considering your HIV diagnosis and the necessary care for your health. How do you perceive your follow-up at the specialized health service? And also we have a socio-demographic questionnaire with age, race, gender, and sexual orientation. We performed this interview into a private and safe environment, and the duration was around 40 minutes audio recording. Um, so the data analysis for the second paper, we also use Datamutec as a software tool to help the organization and processing. And also we use the thematic interpretation by Minayo, who explored the pre-analysis, the material, and the treatment interpretation. And we use the perception of vulnerability framework to understand some individual, social, and programmatic aspects of this population. And we also use the descending hierarchical classification to explain and organize the categories and the results of this paper. We also follow the ethical aspect, like I said, and we find some individual aspects health related by this population. So for the individual dimension, we found men who have sex with men, young adults, they related some risky behaviors, but also they have strong social bonds, especially because their mother and friends, they often related a fear to involve with some person for affective or sexual relation. They have using of condom, not regularly, but they try to use because a lot of people who live with HIV think about the U equal U undetectable, we equal untransmittable, but this idea give um, equivocation idea of protection, but the treatment it's effective if you use the adherence into the health service with regularly behaviors, and this explain the idea of equivocate of protect. I don't know if I could explain, but they have a lower education level, which means more exposure to risky behaviors, and also for infections with HIV. For the social, they have low income, irregular familiar structure, stigma and discrimination into the family, into the social bonds, and they have limited sex education and also access to digital social spaces. For the programmatic aspects, they have easy access to CTA, multidisciplinary support, good care quality, but they often relate the poor structure and privacy issues because the CTA is linked with other primary attention. So they they have a lot of fear to seeing into the health service, into the CTA, and they often call HIV hospital. So this is the problem into the programmatic dimension. So this is this DHC dendrogram who explain the two axes. The first one is individual, social, and programmatic dimension of this population based on three classes. And the other one is living with HIV, paradox and complexities of these young people with two classes. For the first axis, we have HIV positive test, the beginning of new life. Like I say, they try change the idea, the first idea of HIV, and give some motivation and his significance of this infection and the new chronic condition. So they en entry into the service by the testing and the positive diagnosis. They often talk about the health service as a key for acceptance and adherence to treatment. And also, multidisciplinary supports helps to understand the condition. Some examples of speeches of this population: the hospital referred me, they gave me the protocol, and my mother accompanied me. Honestly, I didn't even know about it. I received a social assistant which talked to me and my mother and explained everything. My first test came back positive, and I found out that there was a specific program of treatment of sexually transmitted infections or disease. There's also psychological support, which is really good. So they like of health care service for the treatment of HIV, but it's often associate with a paradox of go to CTA and associate with HIV. Some feelings related to HIV. Like I say, the diagnosis involve emotional reactions like fear, shock, and stigma. And they talk about the importance of support network, especially family. But the family is a paradox of idea, and the mother was the first family who people talk about HIV. The health service also represent emotional and social support. And here's some examples. It made me very afraid of dying, really scared. So I think it did contribute in a positive way. I would say because I didn't die, I'm still here. Also, it was the words they exchanged with me, especially the nurse who made my first diagnosis. He said everything would be fine, that would have normal life. The nurse and the nursing staff say this, which comfort me a lot. And so for me, it's amazing, the healthcare, because it's really amazing to know that there is free treatment, psychological support if needed, and that have all your tests up to date. And the uh, last classes of first access involve the adaptation to treatment, focus in art, adaptation and follow-up, importance of medication and healthcare providers, and access to service improves the adherence. He tells me that if I want to get pregnant, if my partner does not have HIV, it's not a is not a carrier. My child won't be affected because this medication take is designed so I can get pregnant without transmitting it to my baby. So the second axis is based on understand the complexity of HIV. So we have the lack of sexual education and the limited knowledge among young people, especially for some groups. The health professional, it's like key educators, and feelings of guilt and suffering involve the complexity of the diagnosis. And some of examples, all the professionals involved bring this effective, very empathic aspect. I felt very embraced, very supported, and the health professional at the CTA deserve congratulations for the entire process for all the care. And I also had the question and they answered them all because we have doubts in the beginning. We don't have knowledge. I believe they were very patient with me. And the last one, reframing HIV experience of young people in health follow-up. They shift towards safe behaviors and self-care and change the idea of HIV. The health follow-up improves health outcomes, but they have some barriers like a lack of privacy, like I said, a waiting time and stigma service. So some of examples, my health has improved. I was extremely debilitated and I can't explain it, but I wouldn't say it's welcoming environment like, wow, I can't wait to come in here. It's kind of knowing in that sense because they could keep everything separate into the hospitals. Here you arrive, and the next day it's all over town. Oh, they were at the CTA. And whether you like it or not, the clinic is known as the HIV hospital. And but I wouldn't say it's a welcoming environment. Oh, I can wait to come here. Maybe if it were more private, more anonymous, it would be a little more comfortable. Some insights of second paper, we can see the multidimensional vulnerability that involves individual, social, and programmatic factors. Uh, um, Also, the diagnosis as turning point, it's associated with stigma, fear, and uncertainty about the future, about the life, about the project. And there a paradox of that disclosure, need for support, but the fear of stigma and social rejection. The health system challenge, delays, wait time, structure barriers, and need for welcoming approach, trust-based care. And the role of care professional needed to qualify listening and confidentiality. And these characteristics promote adherence and empowerment. And but also we have a lot of gaps in sex education, which contributes to risk behaviors and ongoing vulnerability. And also psychosocial support is a key to improve outcomes and reduce some inequalities. So the study limitations of my project is associate low adherence with 16 participants because we try to interview around 100 young people, but they refuse because they have fear of prejudice, judgment, and stigma. So we can think about the idea of these participants have afraid to share the experience, and also other limitation, it's based on context-specific sample. We study young people and different municipalities. We can limit it general, I'm sorry. The findings reflect a specific group and care context, potential influence of context, and differences in social interaction, healthcare networks, and professional practices. In the conclusion of our research, the living with HIV, especially in young people, is complex, dynamic, and multidimensional. Involves the three dimensions of vulnerabilities. The health service are the central because they start with the diagnosis, they into the treatment and long-term follow-up, but the stigma and discrimination persist, especially for mental health impact. We saw some sexual and health education gaps who increase the vulnerability of youth, and support networks are essential to understand and live with quality of life with a key coping mechanisms. So this is are my references. I'd like to thank you for this opportunity. Sorry for my nervosism, but I try to provide the results of my master dissertation now in English. But this research changed my life and showed to us the importance to understand and give some perceptions of this population to create a better quality of life for this population. So thank you so much.
Thank you, Bia.
Thank you, Bia. Mhm. Come on.
Any questions or comments? I can ask one.
Mhm.
Okay. Beatriz, congratulations on your great work and a great presentation. I thought it was amazing. Methods you picked and courage you had in your mentor to pick such a challenging topic. And I was thinking about a way to address one of the things I thought that were most complicated for the users, which was related to anonymity and the prejudice and stigma. Do you think it would be visible, at least in your in the place where you work, in the place where you research, to decentralize care and use regular healthcare centers like our Unidade Básica de Saúde, so that you don't have a special place where people go to and to be tested regularly and seen and get their medication? Do you think it would be feasible?
I think it's a difficult response because some people who live with HIV want to decentralize care, but they often say that primary care, like Unidade Básica de Saúde, the professionals are not
Trained?
qualified and they don't respect the anonymous, the treatment, the adherence. So the CTA, it's important. It's a good strategy, but here in my city, this CTA is linked with other primary care. So they exposure the people who waiting for the counseling, the attendance. So it's very difficult. So for the perceptions of the young people, I can't answer this question. But for me, I think we need to one place to testing and counseling, but to decentralize the idea, we need to qualify our professionals and give understanding listening without discrimination, without a stigma, without some ideas of these infections is focused in one group or one characteristic. So it's complex. It's complex. So we try to respond this question, but I can't I can't explain exactly because some people want decentralized, but other people don't want to explore and don't they want to hide the diagnosis and not and if the decentralized the care, they maybe can be exposure to primary care, for example. So it's complex. It's complex.
Go ahead, Bruna.
Hi, Beatriz. Good presentation, amazing topic. I love it. I really think a lot about all uh, your presentation. And one thing about Eduardo said right now, and I was thinking about your presentation, then some person in the interview, they say they only know about the CTI when they have the positive test.
Yes.
And about the stigma, I think maybe if it's possible to present the CTI for the when you are in the school and say to the population, this is a health and self place to be if you have some not only issue when you have the positive test, but if you have some doubt, I forgot, but like the question about your if you have or not HIV or others disease, you can um, uh, arrive here and you will
Mhm.
have an amazing team with all the qualified and give you support because
Mhm.
maybe when you only presentate this place when you have the positive test is all a new world. And when I was attend in the city, I was question myself about how I don't know the existence of this place
Mhm.
before. I only know this place because I was a medical student, and if
Mhm.
I never working with healthcare, and if I don't have a positive test, maybe I never know about.
Yes.
And I think is a good presentate this place for kids, and this will help the kids to understand better how working our healthcare system and how complex we can provide a good healthcare. I don't know,
Mhm.
and maybe this will help the sex education too,
Yeah.
you know, something
Mhm.
like this. But it's amazing, and I really love it. The TA place is other is like amazing. The
Mhm.
workers there is really good and really prepared for all the situations. Is
Mhm.
amazing.
Thank you, Bruna. And I agree with you. I really think that sex education is the first approach to minimize the STIs, the HIV, especially in young people. When I heard some stories by participants, it really shocked me because they didn't expect the infection. Some get the HIV by the partner. Uh, some involves abuse. So it's very, very impactful. And I think the CTA is the key for adherence treatment because it's the one place. But I live in a place with some um, good health care, but there are some places that doesn't exist the CTA. So here in my city, we found some complexity and sad stories. If we imagine some other places with complex care, poor care, this idea it's very, very, very complicated. So I think this research, and also just to finalize, but our research was the pioneer here in my city. Never research did this research before. So listen, these people who live with HIV and who experience the healthcare provide some insights to promote the quality of life and understanding hearing of these people. But thank you so much.
Thank you